All right, welcome to The Explainer. Today we're going to tackle a topic that can show up with some of the vaguest symptoms out there but has really profound consequences: pituitary hormone deficiency. Let's build a clinical framework so you can spot it and you can manage it.
So let's start with a classic clinical puzzle, right? You've got a patient, they're tired all the time, they've lost some weight they can't explain, and their labs come back with a little hyponatremia. I mean, these symptoms could be a million different things. But what if the single answer that ties it all together is hiding in this tiny little pocket of bone at the base of the brain?
To even start to solve that puzzle, we've got to understand the local anatomy. So let's get our bearings with the pituitary gland. You've probably heard it called the body's master gland, and for a very, very good reason. Now have a look at this MRI because it shows you that in endocrinology, location is everything. See the pituitary gland right there? Look who its neighbors are. You've got the optic chiasm, where your vision pathways literally cross over, sitting right on top. And on either side, the huge carotid arteries. This isn't just some anatomy trivia for your exams, it's clinical destiny. A tumor that starts growing here has absolutely nowhere to go except into these critical structures. So what is this little gland actually doing? Well, it's conducting a whole hormonal symphony. Here are the 6 major players from the anterior pituitary. Just think of them as messengers. ACTH tells your adrenals to make cortisol when you're stressed. TSH kicks the thyroid into gear. LH and FSH, they run the reproductive system. GH handles growth and metabolism, and prolactin is key for lactation. So you can see how if any one of these messengers goes silent, you're going to have problems all over the body.
So how does this perfectly tuned system actually fail? Let's break down the major causes of hypopituitarism.
And wow, the list of potential causes is huge. By far the most common are tumors, these pituitary adenomas, that just put pressure on the gland. But, we also have to think about the things we do, like surgery and radiation. Then there are vascular catastrophes like pituitary apoplexy, that's a sudden bleed into the gland, and weird infiltrative diseases, head trauma, and yeah, even common medications like opioids can totally knock the pituitary offline. The main way these tumors cause damage is through something we call mass effect. And really, it's just simple physics. A growing tumor physically squishes the normal pituitary tissue, and that shuts down hormone production. And if that tumor grows upwards, it presses on the optic chiasm, which gives you that classic textbook finding, bitemporal hemianopsia, the loss of peripheral vision.
And speaking of vulnerability, get a load of this number, up to 50%. Think about that. Up to half of all patients who have a significant traumatic brain injury can end up with growth hormone deficiency. That is a staggering number, and it really highlights why we have to be screening for this in TBI survivors.
Okay, so we have our suspicions. How do we actually nail down the diagnosis? Let's walk through the diagnostic workup step by step. The approach here is really logical. It all starts with your clinical suspicion, right? Just from your history and physical exam. From there, you order a broad initial screen of all those baseline hormone levels. And then, if those labs come back looking fishy, you move on to confirmatory dynamic testing, where we actually challenge the system to see how it responds under pressure. Now, when we're screening for adrenal insufficiency, which is one of the most dangerous deficiencies, the ADM cortisol is your best friend. This is a super high-yield clinical pearl. A level that's less than 3 is a huge red flag. A level over 15 makes it incredibly unlikely. It's that gray zone in between that means you need to do more digging.
And that next step, that digging, is the ACTH stimulation test. What we're doing here is asking a very direct question. Hey, adrenal glands, if we give you the go signal directly, can you still make cortisol? We give a dose of synthetic ACTH, and we're looking for that cortisol level to jump up above 18. If it does, great, the adrenals are working just fine. If it doesn't, well, you've just confirmed adrenal insufficiency.
So you've got the diagnosis. Now what? The whole game shifts to management. Let's cover the key principles of hormone replacement. Okay, everybody, listen up because this is probably one of the most critical, high-yield points we're going to cover. In primary hypothyroidism, the thyroid gland itself has failed, so the pituitary is screaming, sending out tons of TSH, and that's what we monitor. But in secondary hypothyroidism, the problem is the pituitary. It can't make TSH in the first place. So monitoring a TSH level is completely and utterly useless. You have to monitor the downstream hormone, the free T4. And what's the goal with treatment?
Well, when you're replacing levothyroxine for a pituitary problem, you're aiming to keep that patient's free T4 level just hanging out in the mid to upper half of the normal reference range. That's the sweet spot. All right, this next part is literally life or death for your patients with adrenal insufficiency. Knowing how to manage their steroids during an illness is everything. See, a healthy body ramps up cortisol production when it's sick. Our replacement therapy has to mimic that. For a simple fever, they need to double or triple their daily home dose. For major surgery or sepsis, they need big guns, aggressive IV hydrocortisone. This is absolutely non-negotiable. Whew, okay, that was a lot. Let's boil it all down to the absolute must-know, can't forget takeaways from all of this. Takeaway number 1, anatomy is destiny. Remember that MRI from the beginning? The pituitary's tight real estate explains almost everything. Any growth there is going to cause very predictable problems with hormones and with vision. Takeaway number 2, you have to prioritize. Sure, growth hormone and reproductive hormone deficiencies are the most common things you'll see. But a lack of ACTH or TSH can kill your patient. You always have to assess for those two first. Number 3, that 8 a.m. cortisol is your go-to screening tool. It is so powerful. A value under 3 is a major red flag that something is wrong with that pituitary adrenal axis, and it demands that you investigate further. And finally, takeaway number 4. If you remember one single thing about management from this entire talk, make it this. You never, ever monitor secondary hypothyroidism with a TSH level. It is clinically meaningless. Your one and only reliable guide is the free T4.
So I'll leave you with this one last question to chew on. You've done the work. You've stabilized your patient on the right hormone replacements. They're doing well. But the damage to the pituitary can be progressive. So, for how long do you have to keep looking for new deficiencies to pop up? The answer is, potentially, for the rest of their life. Constant vigilance is absolutely key.